Welcome to Managing MDS. I am Dr. Joseph Khoury. I will be discussing the hematopathologist's diagnostic approach to myelodysplastic syndromes, or MDS. The new World Health Organization classification of myelodysplastic syndromes includes many new changes, the most important of which is a change in the terminology that we're using to describe these diseases. So going forward, we're staying away from terms like refractory anemia or refractory anemia with ring sideroblasts, because of course refractory anemia is a very descriptive older terminology. What we will be using going forward, and what everyone needs to be aware of, is that the term myelodysplastic syndrome will be at the core of these diagnoses. So we will be going forward referring to MDS with single lineage dysplasia, MDS with ring sideroblasts, either with single lineage dysplasia or multilineage dysplasia, and so on and so forth. From a hematopathologist standpoint, when we examine a bone marrow sample to look for features of myelodysplastic syndrome, we examine all three lineages: the megakaryocytic lineage, the granulocytic lineage, particularly the neutrophilic granulocytes, and the erythroid lineage. As you can see in the top left-hand figure, this is a dysplastic megakaryocyte by virtue of detached nuclei and some abnormalities in the way the nuclei are configured within the cell. In the bottom left-hand portion of the slide, you can see two dysplastic neutrophils, one with hyper-segmented nucleus to the left and one with a hypo-segmented nucleus to the right, a nucleus that has two lobes connected by a thin strand of chromatin, what we otherwise sometimes refer to as a pseudo-Pelger-Hüet neutrophil. All these are features of dysplasia that we look for to make a diagnosis of MDS. In the bottom center image, you can see a group of erythroid precursors, of which the two at 11 o'clock and 12 o'clock have multilobated nuclei, which are features of erythroid dysplasia. And to assess whether ring sideroblasts are present or not, we use an iron stain, or a Prussian blue iron stain, that highlights iron-containing granules with a light blue color. The bottom right-hand corner image shows a ring sideroblast, which is an erythroid precursor which contains iron-containing granules lined up around the periphery of the nucleus. Data from the bone marrow and from laboratory studies are critical for patient risk stratification when MDS is the disease in question. Hemoglobin, platelets, absolute neutrophil count are all information derived from the CBC, of course. Bone marrow blast percentage and cytogenetics using conventional karyotyping are two critical pieces of information derived typically from bone marrow specimens. Based on the data that we have on any given patient along these parameters, the patient is assigned various scores and ultimately is risk stratified within one of 5 risk categories, ranging from very low to very high. And depending on these risk categories, prognosis and treatment decisions are determined. It is important, while we're staying on the slide, to remember that the bone marrow blast percentage is a function of the adequacy of the specimen. So when a specimen is adequate, we typically can assess bone marrow blast percentage well. When a specimen has limited adequacy, those data points can be compromised. This is why clear communication between the hematopathologist and the oncology team is of utmost importance towards patient management. Myelodysplastic syndromes fall along a spectrum of myeloid malignancies, where cytopenias are a dominant aspect of the disease biology. On the other end of the spectrum, something we will not discuss a lot today is proliferation biology, which is typically characterized by leukocytosis, by overproduction of certain lineages. And the balance between MDS and MPNs, or myeloproliferative neoplasms, is really dependent on information that we have been learning over the past several years, typically through next generation sequencing based mutation profiling. So depending on the complement of genes that are mutated in a given patient at a particular point in time, the disease typically would manifest with either dysplasia or proliferation. Genes such as TET2, ASXL1, EZH2, and DNMT3A are typically associated with myeloid diseases with dysplastic features. I want to thank you for your attention and for viewing this activity.